Mr. K. Well, I'm Adetunji. I'm a GP partner in Witham. I work with Douglas Groove Surgery. I'm also a GP trainer, as well as one of the clinical directors for the IGROS PCN. My partner is also part of this group, so two of us will run Douglas Groove Surgery together. That's my background, and I do a bit of minor surgical procedure as part of my specialty.
Omar, please mute yourself, Omar. You're causing an interference, Omar. Mute yourself.
Yes, I was saying that. Yeah, I'm a clinical director, one of the PCN here in Witham, which is IGROS, and also I run the practice with my colleague here, Dr. Fatai Salau, and I do a bit of minor procedure, minor surgery as part of my special area. So I welcome you all to this presentation about prostate cancer. And like Annie had said, it's a very hot topic amongst men generally, and particularly amongst ethnic minority men, where you and myself belong. And so today we want to quickly peruse the prostate cancer, see how best we can help ourselves for early detections and how we can get ourselves to look after our prostate. First slide, please. Right. Prostate cancer is the most common cancer in men, both black and white. Men generally have cancer, prostate cancer as the highest cancer, and it accounts for about 26% in male cancer in the UK, and estimated that about 1 in 8 men will be diagnosed with prostate cancer in their lifetime. Most cases occur in older men, about 25%, in men younger than 65, while the 10-year survival rate is over 80%. Almost 10,000 men in the UK die every year, which is second to lung cancer. Let's look at the anatomy of the prostate. When you look to the left of the slide, I'm sure you will see the prostate gland there. And it's a walnut-shaped structure, which is located at the base of your bladder. This is the pouch that actually collects urine, both in men and women. Women don't have prostate, but they have got bladder. So it sits just at the base of the bladder in men. And as you can see, it surrounds the pipe that takes urine from the bladder out through the penile. And also that same pipe takes your semen out to the outside. And the prostate in itself secretes, fluids, which passes through the duct in there, which are seminal vesicles, vas deferens, and they empty their secretions into the prostatic urethra, which is that tube that goes in between that prostate gland. The next slide, please. Now, what are the functions of the prostate? It produces fluid, which form part of our semen. So the prostate as a unit could be malfunctioned. Beyond the fact that it does these functions of producing semen, it also could cause some problems. And problems of prostate could vary from ordinary inflammations within the prostate or an infection, which we call prostatitis, to just benign enlargement of the prostate, which again could occur in people, very common in older men, and that will be a benign enlargement of the prostate, which we call benign prostate hyperplasia. And then the end of the spectrum is prostate cancer, which we'll be talking about today. So An individual prostate could be inflamed, could be enlarged, and could be cancerous. Any of these three could be suffered by any of us here. And so it is important for us to understand the concept of the prostate. Next slide, please. Okay, now let's look at some basic facts. Studies in the UK quote that Black men are at 2 to 3 times the risk of prostate cancer compared to their Caucasian counterparts, with a 30% higher mortality rate. Why is it that we could have a higher mortality rate? I'm sure we're going to look at the reasons as we proceed. 28 per 100,000 men are estimated to suffer from prostate cancer. Thirdly, higher incidence rates are reported due to the use of widespread prostate-specific antigen testing in nearly 3/3 of developed countries. However, in the developing countries, I'm not sure PSA testing is such widespread for now. But in the developed world, it's a thing that is becoming, a norm, and so the rate of peak is higher. The Caribbean populations have the highest rate of prostate cancer in the world, and that's about 26.3 per 100,000 men.
Influence, Woloni.
Sorry, somebody is interfering with us, please.
That's Shegoloja. Can you mute yourself, please?
Now, the sub-Saharan Africans have a rate of 10 per 100,000 population. So which means the Caribbean still have a higher, percentage, but the Afro-Caribbeans generally have been noted to have the higher rate of prostate cancer compared with their Caucasian colleagues. Now, there are factors, genetic and environmental risk factors, in combination with local country health profile and robustness of health registries are likely the cause of variation between ethnic groups. What are they trying to say in here? Like back, in developing world, the registrations of their cancer, incidence is pretty, we won't say it's at the best value at the moment. And so the reporting rate is equally poor. So all these put together might be responsible for the low, incident that have been picked up, because there's poor reporting rate as well as poor registration, which is quite advanced in the developed world where we find ourselves at the moment. Now, the prostate cancer in ethnic subgroups process, which is a study that was done here in the UK, was done actually in Bristol and in London, just to look at how, what's the incidence rate among the Black community. And it was actually found that it is higher. So that, process, which is a study that was done here in the UK, like I said, was actually done in Bristol and London combined. And they include about 2,140 cases in that study. The significantly higher tumor state, Gleason score, and presenting PSA in these Black men may account for the difference. What they are saying in there is that in Black men, the prostate cancer tends to be a little bit more virulent. Why? We might actually allude to that as we go ahead, because the Gleason score is used to actually determine the virulence of the prostate cancer that we are talking about. CAP, which is another word for, just the short form for cancer of the prostate, continue to be the leading cancer for all these men, and the mortality is actually increasing, excluding the mortality of the lung cancer in the Afro-Caribbean men. Next slide, please. What are the risk factors? Age. Increased likely from the above the age of 50. We have said that we in this cohort, we are over 50. So definitely we are all at risk of prostate cancer. But we are under the age of 40, However, as a Black man from age of 45, we will need to be a bit more careful in actually looking after our prostate. The age range generally varies between 65 and 69. Race. Black Africans, like we already said before, the Afro-Caribbeans have the highest rate of prostate cancer. It's more in the Caribbeans and then followed by the sub-Saharan men. So Black Africans are more likely to get it, not Americans and not Europe, just because of the migrations that has occurred. And then we talk about family history. If your father or your brother has a prostate cancer, your chances of actually picking up one is very high. And so once you have a family history of that, you need to be aware that you are at higher risk. Then hereditary breast and ovarian cancer. We have a gene that we call BRCA1 and 2. If somebody's family has this gene in them, mom has breast cancer, then there could be a risk of a co-risk with prostate cancer in any family that has this hereditary breast and ovarian cancer syndrome. And like I've said, they normally carry a special gene, which we call BRCA1 and 2. Now, we look at genetic changes, which equally can cause mutations and impact on our chances of developing prostate cancer. Eating habits. Yes, though there has not been a very robust relationship that has been established. However, there have been scanty of information about the type of diets and how that could influence cancer generally. Not necessarily prostate alone, but general cancer incidence could be increased when we eat high animal fats, when we eat a lot of red meat, and when meat are cooked at a very high temperature. All these will predispose us to cancer generally. Then we talk about obesity. We're looking at central obesity here rather than global obesity. And it is believed that men generally develop central obesity. That's where you have your pot belly, fat deposit in the central area. Those kind of activities who actually predispose us to having cancer. Then we have 1 in 8 men in the UK will be diagnosed of this in their lifetime. Next slide, please. Now, what are the signs and symptoms of prostate cancer? We did said it before that in prostate, you could have inflammatory changes, which we call prostatitis. You could have benign prostatic hyperplasia, which is just a benign swelling of the prostate. And you could have prostate cancer as an entity. Any of these symptoms can present, and I want to say that you may be completely free of any symptoms at all, and yet you could have prostate cancer in there because it's a slow-growing cancer. So you may be asymptomatic, but then when you have symptoms, you may have frequency where you go to the toilet every now and again, as you feel you cannot completely empty your bladder, so you go every now and again. Urgency, it's you are bursting to go. If you don't, you are likely to have an accident. That's an urgency. And then you have nocturia, whereby you wake up at night, urinating 4 or 5 times at night. Normally, if you're waking up more than once, in the night, then you need to start looking at yourself, particularly if you have a very good water intake, regime, and you don't drink a lot of coffee, going to bed. So if you start finding yourself waking up 3 or 4 times in the night, then you need to get yourself checked. Then we talked about bone pain with metastatic disease, back pain, then weight loss, loss of appetite, fatigue, and erection dysfunctions. All these symptoms could present at any stage of this disease. And like we said, we may be free of any symptoms in the initial phase until things begin to play out. Next slide, please. Now, we're looking at stages of cancer here. Basically, you have different zones in the prostate, but because of our setup here, I don't want to barge us with different, intricacies of anatomy. But cancer, could be categorized into 4 stages, just like we have looked at in there. Stage 1, when the cancer is still small and only in the prostate. Stage 2 is larger and it's in 2 lobes of the prostate. And stage 3, the cancer is spread beyond the prostate, close to the lymph glands around. And stage 4, when it has moved generally to the bones, to the spines, and maybe to the liver, and it's gone right the whole body. Then at that time, you will begin to see most of those symptoms that we're talking about initially. Now, how will you diagnose and stage prostate cancer? Basically, the most important thing is clinical history to start with. Like we said, those symptoms that we've talked about, when you speak to your doctors, they ask you various questions. How is your water works like? How many times do you go to the toilet during the day? Do you have urgency? Do you have frequency? When you sleep at night, how many times do you go to bed? Any blood in your urine? Stuff like that. They will ask you, do you have dribbling of your urine? Do you have good flow? All those factors, all those things will be asked you. Now, when that is done, they could do a rectal examination just to feel your prostate, which is, putting hand to the back passage just to feel the prostate, just like, being demonstrated in the picture over here. Though it's not a very pleasant procedure, but it's very important as a part of process for prostate cancer. Now, I'll put in there Gleason score. Well, it's one of the scores that is used to stage prostate cancer. Normally, because of our background, I wouldn't want to bore you down with that. But when you look at Gleason score, what it just looked at is how the prostate cells has actually changed in comparison to a normal cell, and they are graded grade 1 to 5. And so you have 2 different zones whereby you look at. So let's say the cell in zone 1 of the prostate, where the cancer is, when you look at that cells, how it has changed from its normal cell to the cancer cell, you can grade them 1 to 5. And then the other part, where again the cancer is next within the prostate, you take another sample there and look at it again. Again, that's graded 1 to 5. So if you score 3 in one and 4 in the other one, they are both added together to make 7. Anything below 6 is still, taken to be a low graded disease. But from 7 and above, then there's a lot of problem. And then 8 to 10, they are the severe grading that we're talking about. Now, PSA, prostate specific antigen. Well, is this a screening test yet? No, it is not yet a screening test, but it's a test that is specific to the prostate, though not cancer specific. I want you to pick my word there. It's not cancer specific, but it's prostate specific. So when it is done and it is raised, it generates more questions of why is it raised? And that might actually lead to more tests to actually detect whether there is cancer there or not. I must say, the fact that your prostate specific antigen is raised does not mean your prostate will have cancer in it. Inflammation could cause it. Urinary tract infection could cause it to be raised. And so that is why it's not been generally accepted as a screening tool for now, because it is not completely cancer specific. So next slide, please. Now, why do we have this cancer being a little bit problematic in the Black men, I want to say one of the first things will be delayed, reactions to this problem. I think sometimes because of our background, maybe we're a bit reluctant to actually get things picked up early. And so because it's not picked up early, the androgen receptor pathway, which is actually responsible for the growth of the prostate and things like that, when they are more elaborate, then before the testes or they are picked up, then this actually got it's more or less more elaborate in Black men, and it's actually spread and caused more dysplastic cancer, as we call it. And so those androgen receptor signaling pathway, which actually help in developing this, will have elaborated themselves more, and the cancer will have probably spread before we actually pick it up, particularly because we didn't go for check early enough. 2, high testosterone level in men play a factor in cancer of the prostate. Now, then there's another component in Black men, and that is the cytochrome P. Sorry, that might be a bit complex for some of us that are not medics, but this cytochrome P4 actually regulates metabolism of testosterone, and they've been found out to be a little bit of polymorphism in Black men, which may make it a little bit more elaborate. Then the last bit is there's a particular gene, HQ24, which can also cause a lot of problem, which is found in African men. Next slide, please.
Papa Samuel, can you mute yourself, please? Thank you.
Right. So we've talked about this briefly before. PSA screening is a widespread thing in the US, but in the UK, we don't do that for now. However, you have every right at 50 to ask for a PSA from your GP. And I think it's becoming, quite easily, accessible now for us to actually request for that. But in the US, they do it, routinely, and it's widespread. And that's why they picked up a lot of cancer among the Afro-Caribbeans within that setting. PSA, like I said before, is prostate specific, but not cancer specific. Specificity is 40%, whereas sensitivity is about 80%. So it's sensitive, but it's not specific. So you could pick, you could have it, but that doesn't mean you've got cancer. But again, I think it's important for us to embrace this so that even when it is done and it is positive, you can then be subject to further tests like, MRI, other investigations, biopsy, that will help to actually pick whether this is actually there or not. Then you have the direct rectal examination, like we said before. Next slide, please. Now, what of the management? Hello?
Hello, hi, doctor. The management is not in this deck, so you better just talk through it.
Okay, sorry about this. Now, in terms of the management, I think the most important thing is, 1, early diagnosis and surveillance. So you need to actually, once you know that you're a little bit showing the symptoms of prostate cancer, then the next thing is for you to get checked ASAP. Go and see your doctor. If you start having problems, nocturia, your urgency, frequency, dribbling, and things like that, we need to get checked. If you've got a family history, we need to get checked. Now, if somebody has got a prostate cancer, what are the mode of management? The mode of management could be 1, chemotherapy, could be radiotherapy, could be surgical, and then there are hormonal therapy. which you can do. These will vary from one person to the other, depending on the staging of the disease. However, somebody did ask about focal therapy, which is just where they use high energy beam directly on the prostate, on the cancer cells within the prostate. That also is becoming a part of the treatment routinely now within the NHS. So focal therapy is also becoming a normal. I think there's a specialist in that field in London who actually specializes in using focal therapy in treatment of prostate cancer. So generally, like we said, you could have surgical intervention when you have a prostate cancer. You could just have chemotherapy depending on the staging. You could have radiotherapy depending on the staging, or you could have hormonal manipulations, as we call it. And again, we are not talking about focal therapy, which is becoming the norm of the day. But generally, the key thing is for us to ensure that we look after our prostate. Early detections is the key. Go and get yourself screened. Go and get yourself checked, particularly as a Black man over 50. And if you have a family history, those are very significant risks, and we need to get ourselves checked. Thank you very much.
Thank you very much, Doctor. Let me just stop the recording.